Hi, my name is Parampal and today I will give presentation on protection through segregation policy on the behalf of my group. So let's start. The history of the first people in Australia has had a great impact on their health outcome. It also influenced the relationship of first people with Australian healthcare system. There have been imminent disparities of health between non-Indigenous and Indigenous Australians attributed to the history of colonization. The prevalence of disease is higher among the Indigenous population compared to non-Indigenous Australians as much as 2.3% to 2.3 times higher, of which 6.4% of disease burden is associated with chronic diseases such as cardiovascular. This disruption is associated with historical events entailing colonization, marginalization, and oppression. This presentation will therefore evaluate the protection through segregation policy and how the policy influenced the prevalence of cardiovascular disease and how the policy still influences relationship between first people and Australian health system. In this slide, I will briefly discuss protection through segregation policy. The protection through segregation policy was based on the belief that Indigenous Australians were inferior and backward compared to Caucasian Australians. This belief viewed white people as more powerful, while the Indigenous population was believed to be primitive, and they believed that they would eventually become extinct. The protection through segregation policy included Aborigines Protection Act of 1909, which oversaw the forceful removal of children from their families, what became famously recognized as Stolen Generation. The Aborigines Protection Act 1909 justified the removal of children as an opportunity to offer the children education, solace, and protect them from the oppression and abuses the children was facing from their families. The role of removing children, first people children, was assigned to the Chief Protector of Aborigines. The Chief Protector of Aborigines would then assign such children to missions and reserve containing multiple individuals of different culture, which led to the loss of identity. In this slide, I will provide more details on protection through segregation policy. Another Aborigines Act was passed under this policy in 1905 to control labor and wages among the First People communities. The Act introduced negotiated labor arrangements with First People, mostly adolescents. This Act led to increased child labor among the First People, and also sexual abuse of women and children increased. Aboriginal Protection and Restriction of the Sale of Opium Act 1897 was introduced to manage First People and categorize the half-caste on blood quantum basis. The Act demanded that young male half-caste be categorized as Indigenous people, thus receiving the same oppression and poor living state. Aborigines Act 1910 was introduced to eradicate the half-caste through systematic extinction by removing them from their present mission in other orphanages. I will discuss prevalence of cardiovascular disease among first people in this slide. Cardiovascular diseases are leading cause of death and preventable morbidity among first people population. Indigenous Australians' prevalence of cardiovascular diseases 229 per 1,000 person as compared to 152 per 1,000 person among non-Indigenous Australians. Hospitalization for cardiovascular disease is also twice as higher among Indigenous Australians than non-Indigenous Australians. Cardiovascular disease contribute to 25% of all deaths and 25% if all premature years of life lost among Australian First Peoples. Death due to cardiovascular disease occur 10 to 20 years earlier among Indigenous population than non-Indigenous population. The protection through segregation policy is attributed to various social, political, and historical determinants of health among Indigenous population. The policy aggravated oppression and increased inequality, leading to unequal access to healthcare among indigenous population. In addition, the forceful removal and increased control of wages and possessions elevated poverty levels among indigenous population. Poverty is associated with higher incidence and prevalence of cardiovascular disease. Poverty and social economic differences are attributed to differences in risk factor, incidence, and outcomes of cardiovascular disease. In addition, the subsequent poor living condition has also disrupted the wellness among the first people. The first people are more likely to be physically inactive and have lower levels of healthy foods such as fruits and vegetables, which lead to attributes such as being overweight and obese. That increases the risk of prevalence and incidence of cardiovascular disease among the first people. The forceful removal of people from their land and families has caused intergenerational trauma among indigenous population. In addition, the sexual abuses, forced labor, and subjection to oppression measures such as beating and whipping further aggravated trauma in first people. In addition, oppression led to death of multiple family members, leading to depression, anxiety, and other mental illnesses. The history of oppression through colonization and trauma thus led to increased engagement in increased health risk behaviors, include such as cigarette smoking, alcohol abuse, and other substance abuse. Cigarette smoking and alcohol consumption among the indigenous population attributed to high cardiovascular disease prevalence and mortality in first people. The history of colonization, oppression, and marginalization has also contributed to increased incidence and poor outcome of cardiovascular health among first people. In the past, first people experienced discrimination and were often denied healthcare as a result of being regarded inferior and undeserving. Systematic discrimination led to increased mistrust of Australian healthcare in first people that resulted in missed diagnosis, missed care, and prevention of cardiovascular disease that led to poor health outcomes in first people. The history of the protection through segregation policy encouraged oppression, forceful removal, and marginalization, and abuses resulted in increased mistrust and suspicion of white people among indigenous population. In addition, the first people were regarded as inferior and undeserving of Australian healthcare. This led to increased shunning of Australian healthcare by first people. The history of forceful removal of children from their families resulted in increased suspicion and mistrust in Australian healthcare, especially among Indigenous mothers. During birth and delivery, the children would be snatched away in hospitals and taken for bringing in missions and reserves. This resulted in mistrust and poor relationship between first people and Australian healthcare professionals, causing few people in the indigenous population to seek Western healthcare. The relationship with Australian healthcare system were further hindered by the deliberate introduction of diseases, making indigenous people even more suspicious of the Australian healthcare. Additionally, there was the prohibition of traditional medicine practices that was associated with witchcraft, thus made indigenous people even more mistrusting the healthcare system of the Australia. There is still a fear of removal, the ruthlessness of government, and fear of discrimination, leading to inefficient and inadequate engagement of indigenous communities with the Australian healthcare. The communities often view the Australian healthcare settings as unwelcoming, regard with a sense of mistrust and alienation, which are unable to be adequately flexible to offer indigenous friendly treatment options. This has led to increased reluctance to seek healthcare services among indigenous communities. One of the effective healthcare program that has been effective in enhancing healthcare service delivery in 5 districts in Perth is the formation of District Aboriginal Health Action Group consisting of local Indigenous community members. They design culturally responsive healthcare programs in the area. There is also increased cultural safety training programs among non-Indigenous healthcare professionals to promote trust and positive relationships. Individual patient engagement is essential in the provision of patient centered healthcare to the first people. The Australian healthcare has adopted various measures to enhance relationships and build trust with Indigenous patients. The use of liaison officers to improve trust, support, and understanding of cultural preferences, and the involvement of families in the healthcare decision making improves the outcomes in cardiovascular disease care. In addition, cultural competencies and individual recognition of cultural differences among healthcare professionals enable optimization of cardiology and cardiothoracic care in Indigenous patients with cardiovascular disease. The adoption of models to remove individual barriers, such as offering bus transport to individuals in rural areas, enhances individual access to healthcare. In summary, the protection through segregation policy has facilitated the forceful removal of people from their land and families. The policy has also been attributed to various social, political, and historical determinants of health and inequalities leading to unequal access to healthcare among indigenous population. Poverty, trauma, and increased substance abuse were also result of this policy that led to increased risk of various chronic diseases such as cardiovascular diseases in first people population. However, strategies and programs at the institution, community, and individual level can enhance trust and facilitate positive relationship with healthcare professionals.